Thank you. My name's Dr. Daniel Fish, and as stated, the topic tonight is going to be you've been diagnosed with colorectal cancer. Now what? Um, just as an introduction, here's my CV. I have been practicing here at Baystate Medical Center for the past 3 or 4 years, and I'm a colorectal surgeon, so this is well within my specialty. So we're going to be talking about colon cancer tonight, and what do you do after you get the diagnosis of colon cancer? Well, first of all, don't panic. Almost all colon cancers are treatable, and most colon cancers are curable. And even with incurable colon cancer, many people can live for many years. And you might receive the diagnosis and ask, well, what is colorectal cancer? 99% of cancers in the colon and rectum are a specific type of cancer that's called adenocarcinoma. There are other types of cancer, such as squamous cell carcinoma or neuroendocrine tumors or lymphoma. These types are usually not really referred to as colon cancer and are going to be outside the scope of my talk tonight because the vast, vast majority of cancers in the colon are this specific type called adenocarcinoma. And first, I want to tell you a little bit about polyps. Colon polyps are abnormal growths that emerge from the inner lining of the colon. This lining is called mucosa, which you can see here, forms the inner layer of the colon. And these polyps can transform over time and become adenocarcinoma. It's a slow process, though. It takes months to years to occur, and that's part of why people are recommended to undergo screening colonoscopies every so many years. These polyps form and cancer forms due to an accumulation of mutations in the DNA of the cells of the colon mucosa, which are DNA is a blueprint that tells your body cells how to behave. And these DNA mutations can be caused by carcinogenic substances like chemicals in smoke, charred foods, possibly some food additives. But mutations in DNA also occur naturally with time, as your body's cells copy and recopy this DNA over and over and over again throughout your life. Cancer is different from polyps in that it's by definition invasive, meaning that it's growing beyond this mucosa layer and it's invading the deeper layers of your colon wall and potentially spreading to other places in your body. So how is the diagnosis of colon cancer made? Well, it can sometimes be initially suggested by a radiologic test or even an examination. But biopsy of a mass in your colon, which is performed by colonoscopy in almost all cases, is the definitive way that colon cancer is diagnosed. And there's a topic that I'm going to touch on more deeply, but may come up throughout my talk that I just want to point out. This is the anatomy of the colon. The colon is also known as the large bowel, and it is the last portion of the gastrointestinal tract. The food that you eat is processed by your stomach and your small intestine, and nutrients are absorbed. And the waste that remains after this processing goes into the colon as a liquid, and the colon's main function is to reabsorb most of the water. So the stool passes around this organ, which kind of looks like a question mark shape in some ways, and the stool is transformed from a liquid to a solid. But there's a specific part of the specific part of the colon called the rectum. Colorectal cancer is often used to describe this cancer, and the rectum is part of the colon. They're the same organ, and it's the same type of cancer, and doctors will often use the term colon cancer to describe both colon or rectal cancer. But the reason that I bring this up is that due to anatomic features, rectal cancer can be a little bit more dangerous than colon cancer and is treated a little bit differently. And some cancers fall into a gray area but at the kind of the junction between the areas that we call the colon and the areas that we call the rectum. And these are sometimes called rectosigmoid cancers. And so for people who have a cancer in that area, deciding whether your cancer should be treated as a colon cancer or as a rectal cancer is an important step to planning treatment. Now, once diagnosis is made, the next step is staging. And staging means to evaluate where your cancer has spread to. The staging of colon cancer looks at local invasion within the wall of the colon. It also looks at spread to lymph nodes, which are these very small channels that drain fluid from your organs and are involved in your immune system. And then also distant spread of cancer, which is usually called metastases. Colon cancer always starts in the mucosa, the inner lining of the colon, and then it spreads more deeply into the wall of the colon. And sometimes it will spread all the way through the wall and it can directly invade other organs. So like I was saying, the cancer can spread to lymph nodes, which drain fluid from the colon, and these are sometimes called lymph node metastases. And then when they spread to other organs in the body, they are sometimes called distant metastases. Now, when colon cancer spreads beyond the colon and its lymph nodes, the most common organ that it spreads to is the liver, which is an organ that acts a little bit like a filter for things coming from the colon. And the second most common organ that colon cancer can spread to when it goes beyond the colon is the lungs, which in a way act as a filter for your entire body. Other less common sites that colon cancer can spread to are the lining of the abdominal cavity where the colon resides. And this is called peritoneal carcinomatosis. And it can also spread to other lymph nodes elsewhere in the body, or the brain, or bones. And these are less common places for it to spread to. When doctors talk about the spread of cancer, including colon cancer, we often use a coding system called TNM staging. And so if you receive a diagnosis of colon cancer, you may at some point see this coding describing your cancer. And each letter stands for a different aspect of the way that the cancer spreads, and each letter usually goes with a number which describes how it's spreading. The T stage describes the depth of local invasion into or through the wall of the colon. The N stage describes the presence and extent of lymph node metastases. And the M stage describes the presence and extent of distant metastases. And one thing that's important to point out is that the true T and N staging of colon cancer can only truly be known once the cancer is removed from your body and can be examined under a microscope. But before you have surgery, we will often try to estimate this staging by using imaging tests like CT scans or MRIs. Also, when people undergo treatments like chemotherapy or radiation, it can cause a change to this staging, oftentimes by shrinkage of the tumor or disappearance of the tumor from places like lymph nodes. And this is sometimes called downstaging. So most commonly, people know of discussing staging of cancer in a more simplified system of stage 1, 2, 3, or 4, although there's also a stage 0. Stage 0 is non-invasive cancer and can essentially always be cured with surgery or even just colonoscopy itself. Stage 1 cancer is only minimally invasive into the colon wall and is nearly always curable and generally only requires surgery as treatment. And sometimes that surgery can be performed through the inside of the colon rather than removing the entire colon. Stage 2 cancer is more deeply invasive into the colon wall, and this can include tumors that invade other organs through the wall of the colon. But importantly, stage 2 cancer means that the cancer has not yet spread to lymph nodes. And cancer at this stage is most often curable, and some patients will only require surgery, while others will be recommended to also have chemotherapy, or in the case of rectal cancer, possibly also radiation therapy. Stage 3 cancer means that the cancer has spread to nearby lymph nodes, and there can be wide variability in behavior of the cancer. But most of these cancers are still curable. These cancers generally require surgery and chemotherapy, and in the case of rectal cancer, also usually are recommended to undergo radiation therapy. And stage 4 cancer means that the cancer has spread to other organs in the body, like the liver. And these are the tumors that are the hardest to cure, but many can still be cured. They often are treated with chemotherapy as the first treatment, and they sometimes require radiation, or they sometimes require surgery to remove the original tumor or the places where the tumor has spread to, like parts of the liver or the lungs, or both. Now, to make this staging of the cancer, we use some tests to try to estimate it, like I was saying. The CAT scan is the best test for telling us whether your cancer has spread to other organs in your body. It can also tell us more about your cancer itself, like its precise location and whether there is risk of it invading other organs directly, as well as providing clues as to whether there has been spread to lymph nodes. And this is all information that's very helpful for a surgeon who's trying to plan surgery for you. Of note, CAT scan usually requires blood work in advance to check your kidney function, because you will have both intravenous and oral contrast administered. For rectal cancer, specifically, we also use MRI because this gives us even more precise information when it comes to rectal tumors about the precise location of the tumor and the direct invasion of other organs and spread to lymph nodes, and is used in addition to the CAT scan. And sometimes when results from some of those tests are unclear, then other tests like additional MRIs, such as MRI of the liver or needle biopsies, or a PET scan can be helped to use to clarify things. But in most cases, only a CAT scan and an MRI in the case of rectal cancer is needed in terms of imaging tests to move forward with planning your treatment. There are some other tests that we sometimes perform. One that we always perform is what's called CEA, or carcinoembryonic antigen. And this is a molecule in the blood that is made by the cancer, and we will check this before treatment to help us watch for recurrence of the cancer after you've received treatment. Another test which is sometimes performed is genetic testing. This is performed when there's reason to believe that you might be especially genetically prone to colon cancer, and it's considered in a number of special circumstances. One reason for testing is if you're diagnosed with colon or rectal cancer at an age younger than 50. Another reason for testing would be if you have a particularly strong family history of colon cancer, especially if there are other people in your family who have had colon cancer at a young age. Another reason would be if you're diagnosed with having 2 separate colon cancers at the same time, which does occur sometimes. Another reason you might be tested is if you have something called polyposis, and this means that when you undergo colonoscopy, that a large number of polyps were found, usually greater than 20 polyps, but sometimes can be numbering into the thousands of polyps. And then the last reason is that sometimes when we take a biopsy of your cancer with colonoscopy, some special testing will be done on the biopsy, which may detect some genetic features that can be associated with genetically inherited cancer. If you're found to be positive on the genetic testing for mutations which make you prone to colon cancer, it means that you'll be at risk for having additional colon cancer in the future. And for that reason, patients who have this positive testing, it should be discussed with their physicians as to whether they may want to consider having more of their colon removed than just where the cancer is. They also may be at risk for other cancers, which is very variable depending on what the exact genetic mutation that was found was. And they may need to undergo additional tests to look for cancer in other places in their body. They also may be at risk of other family members having the same genetic mutation. And those other family members may want to consider testing to make sure that they are not also at risk for colon cancer. So if you're diagnosed with colon cancer, what kind of doctors should you see? Well, you should see a colorectal surgeon. That's a surgeon. Colon cancer often requires multiple types of treatment, and you may have to see one, two, or all three of these types of doctors. And the doctor who made the diagnosis will refer you, but usually a surgeon or an oncologist is a good place to start. The surgeon is someone who would surgically remove cancer. The oncologist administers chemotherapy, and the radiation oncologist is mostly only involved in rectal cancer cases, but they administer radiation therapy. And all three of these types of doctors, as well as radiologists and pathologists who provide critical information about your cancer, will often meet at a special type of meeting called a multidisciplinary tumor board, where patients' cancers will be discussed, and as well as other features of patients, and a group consensus will be made about what the best treatment plan to recommend for individual patients will be. Here's a picture of a tumor board in action. So talking about how colon cancer is treated, surgery is used to remove the primary tumor and the associated lymph nodes, and chemotherapy is used to stop or reduce the spread of cancer elsewhere in the body. In some cases, patients will be offered palliative treatments, which are aimed at improving the symptoms from the cancer, but not necessarily curing the cancer. Talking about colon cancer specifically, colon cancers that are stage 0 or 1, as we discussed before, usually are recommended to undergo surgery, and that's generally all they need. Cancers that are stage 2 are recommended to have surgery, or sometimes surgery followed by chemotherapy, and that will just depend on the microscopic details of the cancer, and usually a discussion is had with your oncologist about whether or not you should undergo chemotherapy, and discussing what the level of benefit for you will be versus the level of risk. Stage 3 cancers, where the cancer has spread to lymph nodes, usually patients are recommended to undergo surgery as the first operation, and then chemotherapy to follow it to try to reduce the risk of further spread of the cancer beyond those lymph nodes. And in stage 4 cancer, chemotherapy is usually the first step to try and control and reduce the spread of cancer and cause shrinkage of the tumors in whatever sites they're in. And what happens from there is highly dependent on how the cancer responds to the chemotherapy, as well as where the cancer has spread to. And sometimes patients with stage 4 cancer need to undergo surgery before they can undergo chemotherapy, palliative surgery, to help control their symptoms to the point that they are able to start the chemotherapy. And depending on how the cancer reacts to the chemotherapy, that often helps to determine whether additional surgery is possible later. Now, rectal cancer is, as I was mentioning before, is a little bit more dangerous than colon cancer. And one of the ways that it's more dangerous is that it's more likely to come back again in the area where the rectum used to be once it's removed. And for that reason, we will use neoadjuvant treatments, and that means treatments before surgery. And this helps to weaken the cancer prior to surgery in the hopes of reducing the risk of the cancer coming back again. Radiation is used to weaken the cancer and sometimes destroy it completely. And then surgery is often used to remove the primary tumor and the associated lymph nodes. And then this is usually followed up with chemotherapy to stop or reduce the spread of cancer elsewhere in the body. So looking at the cancer by stage again, specifically at rectal cancer, stage 0 or 1 cancer usually, again, can be treated with surgery alone, and sometimes that surgery can even just be through the inside of the rectum and not having to remove the rectum itself. Stage 2 to 3 cancer is generally treated with all 3 types of treatment. The classic sequence is to have radiation therapy first, and this is often called chemoradiation because a little bit of chemotherapy is given at the same time as the radiation to help make it more effective. And then this is followed by surgery, and then that's followed by chemotherapy. Another way that is being used more and more is to give the chemotherapy first, followed by the radiation, and with surgery as the last step in the process. And one of the advantages to this is that oftentimes patients tolerate this sequence better than having the chemotherapy as the last step. And then again, in patients with stage 4 cancer, chemotherapy is usually the first step in the sequence, unless palliative surgery or radiation, which can also be given palliatively, is needed first to reduce symptoms to the point that people can undergo chemotherapy. And then that leaves the possibility, if they undergo chemotherapy first, that leaves the possibility of other surgery or radiation later, depending on how the cancer responds. Now, just to talk a little bit about colon cancer surgery. The goals of colon cancer surgery are to completely remove the tumor, and that does occasionally require removal of other organs if those have been invaded. And for obvious reasons, we want to try to identify that in advance of the surgery so that we can discuss that with our patients and plan for those things. But sometimes we do discover it during the surgery, and we have to, deal with it as it comes. Another goal of surgery is to completely remove lymph nodes that drain the portion of the colon with the cancer. And then we seek to leave healthy ends of colon, which can be safely reconnected with staples or sutures. This is called an anastomosis. And sometimes patients will need to have a temporary ileostomy bag to allow that anastomosis to heal before you start using it. And in that situation, a second surgery a few months later is required to remove the ileostomy bag. And Occasionally, we decide that due to the location of the tumor or due to factors about the patient, such as other diseases that they have and their overall condition, that a permanent bag may be required. But that's an unusual case. And these are some different colon cancer surgeries. This is that question mark shaped colon again, and you can see different ways to remove parts of the colon so that you are achieving the goals described above, to make sure that you remove the lymph nodes and also to leave healthy parts of the colon that can be put back together again. And there are different surgery techniques that we use for treating colon cancer. Open surgery is kind of the classic form of surgery, requiring a large incision down the middle of your belly. And it's often necessary when patients have had a lot of previous surgery, or if they have very large or complicated tumors, or if they have certain other medical problems that wouldn't allow for other techniques. But what we hope to do for as many patients as we can is minimally invasive surgery, because this offers faster recovery and also helps to decrease some risks, although it is more technically challenging. And anytime we do minimally invasive surgery, we have to be prepared for the possibility that open surgery will be required. And there are two types of minimally invasive surgery often discussed, which are laparoscopic and robotic surgery. But in many ways, these are really very similar. Occasionally, for very early stage cancers, we can remove the cancer from within the colon, and this is called transanal or even colonoscopic surgery. Of note, though, this technique does not remove the lymph nodes, and it makes the final staging somewhat incomplete. And so we have to be very selective about which patients can undergo this kind of approach. Now, when it comes to recovering from colorectal surgery, some details that patients often want to know about are that the surgery can take anywhere from 2 to 8 hours or even more, depending on the complexity of the tumor and what needs to be done. Minimally invasive surgery often takes quite a bit longer because we have to move in a kind of a slower and more meticulous fashion. After surgery, people will often be in the hospital from anywhere from 3 to 7 days, and that's mostly driven by the need to recover the ability to eat and to be able to pass stool, which can really vary quite a bit from person to person in how quickly they will recover that. What people will often want to know how long they can, how soon they can return to work and activities, and non-physical work and activities. Some patients may be able to return within 2 weeks, but return to strenuous physical activity may require at least 2 months because of the risk of having a hernia at one of their incision sites. Transient weight loss and persistent changes to appetite and diarrhea are often things that can occur after colorectal surgery, but these things generally all return to normal within few to several weeks after the surgery. Now, complications are always something that we are concerned that can happen, and we do everything in our power to prevent, but they still can occur. And if they do, that can prolong recovery times. Chemotherapy for colon cancer is given to prevent the growth of cells, and it does affect your whole body, but it to a much greater extent affects the cancer, and that's the idea behind it. The type of chemotherapy most often given for colon cancer is called FOLFOX. That's an acronym, and it really is a regimen of multiple different medications. And these are given in 3-week cycles of infusion of medication followed by rest. And depending on the person's cancer, they may receive anywhere from 3 to 12 cycles of chemotherapy. And adverse effects are not uncommon, but they are usually not overwhelming. And the most common effects can be nausea, diarrhea, fatigue, numbness, tingling, sores on the fingers and toes. And a question that I often get is, will I lose my hair? And with this type of chemotherapy, you will not. Radiation therapy for rectal cancer, like I said earlier, is often given with low dose chemotherapy, which makes the radiation more effective. And the treatment overall is a bit shorter, but it's a little bit more intensive. You receive treatment every weekday for about 5 to 6 weeks, although the treatments themselves only take maybe 30 to 60 minutes each. And there can be adverse effects from this as well. In the short term, there can be pain and diarrhea and fecal incontinence, but that tends to clear up fairly quickly. In the long term, sometimes radiation can cause some other effects like bleeding, pain, fecal incontinence, or sexual or urinary dysfunction. After treatment, most people are largely able to return to their previous lives. This is something that they can put in their past. Some mild effects are not uncommon, maybe some slightly increased frequency of bowel movements or slightly looser bowel movements or some occasional stomach cramping. When it comes to rectal cancer specifically, there also can sometimes be some degree of fecal incontinence, although it's usually mild. And for many patients, they don't have that. Some issues with sexual dysfunction can also sometimes occur, or issues with urination. Now, of course, anyone diagnosed with colon cancer is very concerned about what are their chances of survival. And I don't want to dwell on numbers too much, but the important thing to understand is that especially with earlier stage colon cancers, the rates of survival are very, very good with proper treatment. Predicting survival for any individual patient is incredibly complex, and every tumor has unique features and behavior. Remember that these tumors occur due to mutations in the DNA, and every tumor has different mutations, and so they all act differently, and so it's sometimes unwise to generalize across large groups of patients. Earlier stage disease generally has very good results, as I said. Spread of the cancer to lymph nodes increases the risk of the disease coming back, and spread to other organs does make the cancer hard to cure, but some of these cancers can be cured. Once you have been treated for colon cancer, you will enter a program of colorectal cancer surveillance. And for all stages of cancer, that involves a colonoscopy in 1 year, and then every 3 to 5 years for the rest of your life. Because someone who has had colon cancer, we know is at risk for having more colon cancer in their future, although most people don't. And colonoscopy and being fastidious about doing colonoscopy will help to prevent that. Patients who have had stage 2 to 3 colon cancer or rectal cancer are recommended to have a CEA level, which we discussed earlier, checked every 3 to 6 months for 5 years. And that helps to keep a close eye out for signs of the cancer coming back. And one of the best tests for looking for signs of the cancer coming back is a CAT scan, which is performed at least once a year for 5 years. After about 5 years, most people are thought to be cured, and there's a lower risk that the cancer could come back, although it has occasionally been described of the cancer coming back later. Patients who have stage 4 disease, it's much more complicated because it's going to be dictated by what their ongoing treatment is. But if they can get to a state, no evidence of disease, it's called, where all the cancer has disappeared or been removed, then they'll likely be entered into the same kind of surveillance program. And so that brings me to the end of my talk, and I'm happy to take any questions.
Thank you, Dr. Fish. That was really informative. in a great pace of the talk. I appreciate all the details, and I'm sure our audience does too. There are a few questions. The first one uh, is CEA a baseline test?
CEA is checked to get a baseline CEA before the cancer is treated because some tumors will make CEA and some don't. And how much CEA they were making before the treatment helps us to understand what the likelihood is that they're going to make CEA if the disease comes back. And so cancers that have a high CEA level before treatment, we have the advantage of being able to use the CEA to monitor patients for return of the cancer. There are also other types of blood tests that are currently being researched to help us to keep an eye out for return of cancer. And I'm hopeful that in the coming years, we're going to have more tools to work with to help us do this.
Thank you very much. The next question is radiation an adjuvant therapy for rectal cancer?
Radiation is most often given as a neoadjuvant therapy for rectal cancer, meaning that it's given before surgery. And the reason for that is that it will help to shrink down the tumor, which makes it easier to remove surgically and safer to remove surgically. And also, the effects of the radiation on the rectum will then be removed along with the rectum. It can be given as an adjuvant therapy, which means to be given after surgery. And sometimes we do decide that that might be in the patient's best interest to help reduce the risk of recurrence of the cancer. But we find that patients tolerate it better, and it has some advantages if we give it before the surgery.
Thank you. And the next question, what's transient weight loss?
Well, after surgery, people will often have a decrease in their appetite, and that can cause them to lose some weight after the surgery. And so, that usually turns around within a few weeks after the surgery. And so, people often will tell me that they've lost weight, and I have to reassure them that that's normal. But if that keeps going on, then we have to be concerned about, whether there's something that's affecting their ability to eat. But for most patients, they stop losing weight. Some patients are happy that they lost weight, and I tell them, as long as you don't continue to lose weight, you don't have to necessarily regain it.
Thank you. Is there social work or therapists available or recommended for patients going through this?
So whenever patients, I can speak most to the surgical aspect of the treatment, but whenever patients undergo surgery, we have a social worker in the hospital who will work with them with regard to any issues that they have. Sometimes that can be related to physical therapy that they might need, either before they can go home or at home. It could be related to having a nurse that comes to their house to help them if they have wounds or an ostomy bag that need additional care. Sometimes social workers can just be there to provide emotional support. And so I didn't get into it in detail, but we have a lot of support resources that we organize for patients to help them through this process.
Thank you. I do appreciate your time with this presentation after seeing patients all day and being in surgery and so forth. So it's really wonderful that you gave your time and to share on this important topic.
I'm happy to do it. I'm always happy to share information with patients and help them to learn more about their own bodies and make the most informed decisions that they can.
It looks like we have one more question. This could be the last one. What's the biggest mistake you see patients make related to treatment or recovery?
I think ignoring your disease or ignoring the recommendations of the physicians sometimes can be a big mistake patients can make, sometimes maybe out of fear or hopes for some kind of miraculous change or distrust in the information being provided. Patients will decide not to undergo these treatments. And to be clear, I would never force any patient to undergo any treatment, but patients will choose not to undergo treatment, period, sometimes. And these cancers usually are not, they are slow growing, but they will grow. And if we don't tackle them, they're going to get out of hand. And colon cancer is very treatable and very curable when it's in an earlier stage. And if we don't address it, then it will progress to a more advanced stage when it becomes much harder to treat and cure.
That's a great message. So we all need to get our colonoscopies when we're due.
That's right. Colon, it's a little bit outside of the topic that I was presenting on tonight, but colonoscopy is the best way to find colon cancers when they're at an early stage, and also to find colon polyps, which can be removed and thereby prevent them from turning into colon cancers. And so colonoscopy is really the cornerstone for preventing colon cancer.
Excellent. Thank you, Doctor, for your time, and we appreciate the great information. Thank you so much.
Thank you.